As a continuation of classes on dysphagia, today I'll explain the gold standard investigation for swallowing disorders. What is that? Gold standard in the investigation and diagnosis of dysphagia. The investigation is videofluoroscopy. So this videofluoroscopy is a dynamic fluoroscopic imaging procedure and it shows us all the stages of swallowing. It was described along with the physiology of swallowing, the stages. So all that stages can be seen by doing a fluoroscopy, and also the rapid and also the integrated movement of the oral cavity, the pharynx, larynx, palate, and also the esophagus. All these can be seen. So the anatomical, physiological and also the structural abnormalities causing dysphagia can be found out by doing a fluoroscopy. And actually this needs a multidisciplinary team for doing a correct interpretation and the procedure of fluoroscopy. So by fluoroscopy we can find out the cause of dysphagia and also can decide on the correct modality of treatment, and this can be shown to the patient. So it is actually working as a biofeedback technique. So as a patient can see the fluoroscopic images, the correction of or the maneuvers needed for correction of dysphagia as a part of rehabilitation, that can also be done by doing a videofluoroscopy. So how it is done?
The typical imaging equipment found in a modern radiology department is required, along with the special commercially available CT, videofluoroscopy specific contrast materials, and an ability to make high quality video or digital recordings with the sound with the capability for slow motion and frame by frame analysis. Downloading the study onto the computer enables dynamic swallow study measurements. And the standard protocol is utilized for administration of radiopaque material, which is usually used as barium mixed with the liquid and food of varying consistencies in smaller to larger amounts and thinner to thicker viscosity. The typical protocol utilizes thin liquids, then thin liquid, for example nectar, puree, and solid, usually cookies coated with puree as our standard administration. And some clinicians bake with barium to incorporate barium throughout the solid bolus, but you should note that barium sulfate become toxic when cooked. And whenever possible, the patient is seated as upright as possible, and sometimes the study is performed with the patient in the standing position for a faster study when it is safe and acceptable to the patient. And all studies are started with the patient in the lateral view where aspiration is most efficiently detected, and then it is finished with an anteroposterior view to assess swallow symmetry and vocal cord function. Observation of the vocal cord movement on pronouncement of the vowel R by the patient is often used as an end point of the study. So by this, the flow, then the misdirection and residue of the bolus can be studied. The reaction to penetration or aspiration can be studied. The oropharyngo-esophageal muscle movement and timings of each can be studied. And this is an important role in detecting dysphagia in the absence of an overt symptoms of dysphagia, such as when silent aspiration occurs.
After the procedure, analysis part is the most important thing. So an experienced clinician can give details on subjective as well as objective aspect of analysis. So subjective interpretation on the bolus flow, reaction to a misdirected bolus, and also normal anatomy and physiology. And over a period of time, or if there is to get a consensus over different clinicians, a rating scale has been developed, and the subjective analysis can be rated on that. So we will get a more correct interpretation. And on the objective analysis is on dynamic swallow study measurement or kinematics of swallowing. Okay. Of swallowing. In this, there is capturing and manipulation of the digital images using computer technology, so that the exact timings and details regarding the oral transit, the pharyngeal transit, laryngeal valving, and also the penetration, aspiration, all details can be obtained. If you want to know the exact methodology, it is beautifully given by Leonard and Kendall, and you can refer that. These are the advantages of video fluoroscopy, and many of this comes under the disadvantages of fees. Please see the video on fees, that is flexible endoscopic evaluation of swallowing. Link is given in the description box. So the advantages of video fluoroscopy is that we can visualize all stages of swallowing, and we can get a quantitative estimation of aspiration, which was a major disadvantage of fees. Here we can get a quantity, how much penetration is there, how much amount of aspiration is there, can be clearly estimated. Then safety of therapeutic or rehabilitative strategies can be evaluated, and in regard to the food, full range of consistencies of the food can be tested by doing a video fluoroscopy, and also we can detect anatomical abnormalities, and it's an excellent tool for the biofeedback to patient, as a patient can see the either a real-time basis or the recorded videos. Patient himself can assess the improvement or the treatment, response to treatment, and also especially while doing some therapeutic maneuvers to improve dysphagia or improve the swallowing function, that can be done by the patient by seeing the video of video fluoroscopy. So these are the advantages. Limitations of video fluoroscopy. One is radiation exposure, especially in cases of lengthy and repeated procedures. But a 3-minute of video fluoroscopy, the radiation exposure is equivalent to 2 cervical spine radiographs, and also the exposure or to scattered exposure to the surrounding is also within accepted values. And the cost is high because of the instrument, and also repeat or multiple staffs are needed, so the cost is a problem, and sometimes the patient can be intolerant to the procedures, and also there are difficulties with the seating, especially in a very confined spaces, so that is also a disadvantage. And you are giving a barium coated food to coat the structures, so sometimes it will not behave as the same way as a normal normal food and liquid. So this can be improved, this limitation can be improved to a certain extent by giving a video fluoroscopy specific contrast materials. Then the details regarding the mucosa, the secretion, sensation, then interbolus pressure, and details of glottic closure is not available by doing a video fluoroscopy. Then to make it a better, as of now it's the gold standard, but to improve it, I already told you in the analysis part, subjective as well as objective interpretation are coming. So a greater standardization with a higher inter-judge reliability between the clinicians are needed to make it much more reliable. So all these are the limitations of video fluoroscopy. Then coming to the contraindications. These are the contraindications. Patients without a pharyngeal swallow, that we discussed along with the causes of dysphagia, mainly the CNS neurological patients. So in these cases, if there is patients having absent pharyngeal swallow, they are definite candidates of aspiration. So this should be, video fluoroscopy should not be done in them. Then unsuitable patients, like patients who are not able to maintain the position for the procedure, or drowsy patient, uncooperative patients, and also patients having an adverse reaction or hypersensitivity to the barium or whatever the dye. Okay, so in that they are unsuitable patients, so it should not be done. Then patients with, if you are anticipating large volumes of aspiration in a patient, actually it is not an absolute contraindication, but high level of caution should be there if you are anticipating large volumes of aspiration. And in that cases, an initial small volume of solo, that is less than 5 ml, very small volume solo testing, and that too use water soluble dyes or contrast materials like Gastro Micro or Omnipack. They are water soluble and isotonic. So gastrografin should not be used. If you are anticipating large volumes of aspiration, gastrografin should not be used because it is hypertonic, and if aspirated it will cause pulmonary edema. Okay, so if you are anticipating patients with large volumes of aspiration, or if there is a history of cardiac arrest or respiratory distress because of aspiration, then go with this. So these are the contraindications of videofluoroscopy. The main risks involved are, I already explained. One is radiation exposure, and also another one is aspiration. Okay, so radiation exposure and the chance of aspiration are the risk involved with this. So as I already told, in the case of along with any procedure, it is better to take an informed consent. Here also the same is applicable. So radiation exposure and aspiration are the risk involved in this. And what is the difference between this and a conventional barium solo? You have seen barium solo films, and it is mainly done by radiologists, and it is mainly for the distal problem, that is esophageal motility disorders, strictures, pharyngeal pouch, etc., and also more distal part of esophagus. And if you want to get a detailed soloing phases of the oral as well as the pharyngeal, and also the penetration and also the aspiration details, we have to go with the videofluoroscopy. And this videofluoroscopy is done by mainly done by the speech pathologist. So this is the basic difference between these two. So more dynamic, more advantage is with the videofluoroscopy than doing a barium solo.